My name is Marielle Baldwin. Really great to be here today. Thanks for having me. I'm a family medicine physician, addiction physician at Boston Medical Center. I'm the medical director for BMC's START Clinic, which is the stimulant treatment and recovery team. Work with Ruchi, fortunately. It's an extension of our office-based addiction treatment program. It offers support to and management for people with stimulant use disorders. And just want to say a quick note of thanks before I get started to the Graken Center for Addiction, TTA, team at BMC for their support of this presentation. Today, I'll be given an overview of stimulant use disorders. START receives funding from BSAS, the Bureau of Substance Addiction Services. I have no disclosures. I will be discussing off-label medications for the treatment of stimulant use disorders. Objectives today are to understand how and why people use stimulants. We'll be focusing on cocaine and methamphetamine to understand some of the neurobiology associated with stimulant use. We'll talk through the medical complications of stim use, options for stim use treatment, and stimulant intoxication, otherwise known as overamping. And then we'll close with a discussion of START as a model of care. Just to start with some basics, I know many of you probably know these things, but a quick review on cocaine and methamphetamine. So stimulants, psychostimulants, commonly called uppers, are drugs that increase the activation of the central nervous system. Cocaine was originally derived from coca leaves. It's been used over time in food and medicine. Excuse me, go back. There we go. There are a few different preparations. So there's the water-soluble hydrochloride salt. There's the water-insoluble base. Most common route of use for cocaine is intranasal use of the hydrochloride salt, so sniffing or snorting, powder cocaine. The hydrochloride salt can also be transformed into a base, which is smokable by processing the drug with dilutants, water, heat. Most street preparations that folks get have impurities and adulterants, like fentanyl in them. So the actual cocaine that's typically in street products that's sold is very small. Cocaine is a substance that's rapidly metabolized, mostly in the liver. As far as pharmacokinetics go, intranasal use has the slowest onset of action and more prolonged activity. So it's a half-life of up to 90 minutes when compared to injection use or smoking, which can last for seconds. Has the shortest half-life. You may hear some patients or people talk about freebasing, which is a technique to kind of remove impurities and produce a pure or more potent form of cocaine. As far as methamphetamine, meth is lab-derived from ephedrine components that are kind of mixed in with other easily obtained chemicals like acetone or ether, anhydrous ammonia. Here on the top, you can see the crystalline product, so crystal meth. People often say these are some terms that you may hear folks use to refer to meth. A lot of my patients use T or Tina. Many routes of use can be orally ingested, used intranasally, smoked, injected, used intrarectally and intravaginally. It's metabolized mostly both renal and hepatic clearance. The difference between meth and cocaine is that meth has a high bioavailability. It's highly lipophilic, and so it can cross the blood-brain barrier much more easily than other stimulants, much easier than other drugs. It's slowly metabolized in the body, so it has a very long half-life, about 10 to 12 hours, no matter the route of use. And so this is one reason that we see such significant neurotoxicity from meth use. It has many of the same acute medical effects that you can see kind of listed here on the bottom as cocaine does, but comes generally with much more clinically significant psychosis. And this is largely due to the neurotoxic effects of meth. Just going to run through some epi slides. So this data is adapted from the most recent National Survey of Drug Use and Health, reports that show that demographically, methamphetamine use is most prevalent among indigenous communities. From the same NSDUH data set, here you can see that the percentage of individuals identifying as lesbian, gay, bisexual who also report methamphetamine, gender and sexuality diverse groups, specifically men who have sex with men, women who have sex with men, transgender individuals have much higher rates of stimulant use than do their heterosexual counterparts. and bisexual women and gay men have the highest reported use of methamphetamine. These data compare cocaine and meth use among racial and ethnic groups here on the left, and then gender and sexuality diverse groups on the right. So cocaine use, and then something that's not depicted here, but cocaine-involved overdose deaths are highest among Black and Latinx folks. Both cocaine and methamphetamine use is more prevalent among gender and sexuality diverse groups, and cocaine use is particularly common among gay and bisexual women. You can see here that stimulant-involved overdose deaths from both cocaine on the left and psychostimulants, mostly methamphetamine, on the right, have been pretty steadily increasing since about 2015, both with and without opioid involvement. And I know it's a little hard to see, but the yellow line here on both graphs is where you can see that rise of synthetic fentanyl. And that's really what is driving these stimulant-involved overdose deaths, which is really consistent with what we know about the contaminated drug supply. And this 2020 data show that cocaine-related deaths are higher, have historically been higher in this region, the Northeast, while methamphetamine-related deaths have been more concentrated in the mountain western states and in the Rust Belt. So in 2017, West Virginia had the highest death rate from methamphetamine. And of course, as you all probably know, those of you in practice or those of you who are peers or recovery coaches, since 2020, we've seen a real shift, right? So we're seeing a lot more methamphetamine, a lot more stimulant use here in the Northeast as well. This is the chart for methamphetamine. And I think this graph, others have kind of pointed to this, but this graph really highlights that disparity in overdose death rates from methamphetamine by race and ethnicity in the US. This is specifically focused on people ages 25 to 54. And what you can see here on that top line in blue is that Indigenous people have significantly higher overdose death rates from methamphetamine use. In fact, deaths in the Indigenous communities quadrupled from 2011 to 2018. So really significant disparities there. And this probably goes unsaid, but many of the disparities that we see in patterns of use and overdose death rates, in particular from stimulant use like cocaine, we know, and the inequitable rates of incarceration for Black, Indigenous people of color are really the result in large part from the intentional racist drug policies. For example, in the 1980s, the Anti-Drug Abuse Act imposed a 100-to-1 sentencing disparity for crack cocaine, which is mostly used in Black communities versus powder cocaine used mostly by affluent white folks. And this led in large part to the disproportionate rates of incarceration of Black folks that we've seen over time. So here we'll talk a bit about how and why people use stimulants like cocaine and meth. We'll talk a little bit about how they work in the brain, and then just some key points about stimulant use patterns and health effects. There are many reasons why people use stimulants, prescribed and non-prescribed. For one, they can be highly reinforcing and feel good. Others use to increase energy, attention, to increase wakefulness, thinking about our folks who are experiencing homelessness or who are sex working and needing to stay vigilant at night, literally for their own safety. For many, sexualized drug use, often called chemsex, enhances sexual experiences. We see this in particular with men who have sex with men and trans women who have sex with men. And some folks use in combination with other sedating substances like opioids or alcohol to kind of counteract the depressant effects of those drugs. And just a little bit about the neurochemical transmission, because I think it's helpful in understanding some of the effects of meth and cocaine. So normally dopamine is released into the synapse, into this little gap between the neurons. The neurochemical transmission occurs, dopamine is taken back up into the presynaptic neuron and waits to be re-released. With cocaine, dopamine is released, but then the reabsorption or the reuptake is blocked. And this causes really excess neural activation of dopaminergic pathways. With meth use, the dopamine reuptake is also blocked and the dopamine released is significantly increased. So this leads to much higher concentrations of dopamine that we see even with cocaine, like on an exponential level. And so this increased dopamine release and then the blockage of reuptake both elevates dopamine levels significantly and for much longer periods. And so this produces reward in a sense, much more than kind of a natural rewards we may seek, and more than other substances like alcohol, opioids, cannabinoids. And this excess dopamine is really responsible for a lot of the motor, impulsivity, and mood symptoms that we often see with stimulant intoxication, overamping. And so the important thing, this is methamphetamine, the important thing is that with continued use, in particular of meth, dopamine receptors are downregulated over time. And so for people who are using methamphetamine chronically, it can really take 12 to 18 months for those of abstinence to reverse that decrease in dopamine transporters. And even then, some people will never really see complete repletion of dopamine. And this can, of course, contribute to chronic mood, motor, and memory deficits, including severe depression, suicidality, sometimes Parkinsonian symptoms as well. We do see binge use more often with stimulants than with other substances, and we know that binge use often results in more severe side effects and adverse events. So typically, we see that cocaine binges are on the order of like 2 to 3 days. On average, meth binges typically last a bit longer, on the order of about 4 to 5 days. And then most people, the vast majority of people who use psychostimulants or methamphetamine in particular, do experience withdrawal once they're abstinent after prolonged use or chronic use. Like we talked about, dopamine stores can take quite some time, over a year to recover in some cases. And so withdrawal symptoms we know can last for weeks, sometimes months. Really, it's that first week when we think about acute withdrawal. And this first 1 to 2 weeks are really the most critical for support for patients. People can experience really profound depression, active suicidality, really intense cravings, poor concentration, sleep disturbance. That post-acute withdrawal phase is kind of in the 2 to 4 week period. Lots of people still with mood instability. This is when people start talking about really vivid nighttime awakenings from dreams. Some people call them drug dreams. And then the late protracted withdrawal is what we see generally after about 4 weeks. And this is sometimes described by people as like a cognitive dullness, some memory impairment, really even some like motor impairment, pretty moderate still mood symptoms, mostly anhedonia, depression, with continued cravings. And these are just some examples of the health consequences from both acute and chronic cocaine and methamphetamine use. As you can see, it impacts nearly every organ system. We see we see many people with cardiovascular morbidity. We see significant liver disease, and we have a high prevalence of folks who have HIV and other infectious diseases like Hep C. And then we do see the majority of our patients additionally have comorbid psychiatric symptoms, and a sizable number have stimulant-induced psychosis. And I just wanted to spend a minute talking about coca-ethylene toxicity, because I think this is something that's often overlooked, but it's really critical when thinking about concurrent cocaine and alcohol use. So many of our patients use both, and so this is an important conversation to have with your patients. Coca-ethylene is a psychoactive substance. It's formed when cocaine and alcohol are used together. Alcohol is often used to come down, or as a landing gear, so to speak, from cocaine. It can also be used to prolong or potentiate the effects of cocaine. It's much more potent. It has a larger volume of distribution in the body. It has a longer half-life than cocaine alone. And some studies have cited it being up to 10 times more cardiotoxic than cocaine alone. So there's significantly increased risk for liver injury, for death. So bottom line here is, when you see patients who are using cocaine or alcohol, ask about the other one, right? And talk to them about the disproportionate effects of using both together. A bit about treatment for stimulant use disorder. The short and simple is that a lot of medications have been studied. None are FDA approved, but there are a few with promise based on the research that we do have and that are used off-label. We definitely use medications we try to use all the tools that we have and start. So there's some preliminary research for the ones listed here, and I'll kind of go through a few studies with you. For cocaine use disorder, topiramate is one of the more commonly talked about medications for cocaine use. I'll just highlight one trial here. It was a randomized control trial conducted over about a 6-year period from 2005 to 2011. Had a little close to 150 participants. They studied over 12 weeks. The primary outcome they looked at was weekly abstinence, which was measured by urine drug screens, negative for cocaine. They also looked at self-reported functional assessments, and they were really looking at asking about cravings. And they found that topiramate up to a target dose of 150 milligrams BID, or twice a day, was effective to a statistically significant degree in promoting abstinence. They also noted decreased cravings, all when compared to placebo. There's been a subsequent systematic review and meta-analysis that's kind of had more mixed results. But even in that meta-analysis, it did indicate some signal for a short-term reduction of cocaine use with topiramate. It's also been studied in combination with prescribed amphetamines, which I'll talk about in just a minute. I get lots of questions about amphetamines in general and prescribed amphetamines. And so there have been several studies to evaluate for efficacy of prescribed amphetamines in the treatment of cocaine use. Most of them looking at mixed amphetamine salts like Adderall. And this RCT was done by Fran Levin's group out of Columbia. They followed 126 participants with both a diagnosis of ADHD and cocaine use disorder over the course of 6 years. This was conducted at 2 academic health center sites. And what they found was that extended released mixed amphetamine salts in robust doses, so these were like doses of 60 milligrams to 80 milligrams, sometimes higher, was effective for reducing cocaine use, which was measured by urine drug screens, and reducing cravings in people with ADHD and cocaine use disorder. So you can see here on the top is the placebo group, and then in the middle, the orange line is 60 milligrams. The bottom line, which had the most signal for effect, is in blue, and that is using 80 milligrams of mixed amphetamine salts, so really high doses. You know, sometimes we get patients who come in and they have ADHD, cocaine use, and they come in and they're on 20 milligrams of Adderall, and their provider has like transitioned them to us saying they're still using cocaine. I'm going to take them off their Adderall, and we're like, let's actually increase their Adderall, right? They're not on a high enough dose. In terms of the combination mixed amphetamines and topiramate, this is a data from an RCT that was published in 2020, was really looking at efficacy of using extended released amphetamine salts in addition to topiramate for the treatment of cocaine use disorder. So these patients did not have comorbid ADHD, just cocaine use disorder alone. They used doses of amphetamines of 60 milligrams a day and topiramate of 100 milligrams twice a day. It was conducted as a proof of concept study. So there's a prior study done a few years before this that did show this as an effective treatment for cocaine use disorder. They followed 127 adults for 12 weeks and basically found that what they defined as long-term abstinence, which was 2 to 3 weeks, so not very long. But over 2 to 3 weeks, they found a clinically significant reduction in cocaine use compared to the placebo group, consistent with the prior study results. And then this is from a 2019 meta-analysis that looked at about 50 RCTs, 7 systematic reviews. They looked at over 60 meds and drugs and drug combinations for cocaine use disorder. They looked at different effects, including abstinence, retention and care, return to use, prevention of use, or recurrent use. Antidepressants were the most commonly studied drug class, but really appear to have no effect, unfortunately, on cocaine use or treatment retention. It did show some positive signal in prevention of return to use, and this was mostly for patients with comorbid mood symptoms. They did find increased abstinence associated with bupropion, topiramate, and psychostimulants. The evidence quality was low to moderate. Notably, there was some moderate quality evidence for efficacy around antipsychotics in terms of improved treatment retention. Of note, because this is another question that we get often, is baclofen has not been shown effective at any dose in any of these domains in treating cocaine use disorder. That does not mean that we will not use it in a harm reduction capacity, but in terms of methamphetamine use, that you all are probably familiar with the study from New England Journal 2021, which looked at the combination of high-dose bupropion and IM naltrexone or Vivitrol for meth use disorder. It was a multi-site, really well-done trial. And they looked at folks in 2 different stages. And you can see here on the graph that in both stages, they're assessing primary outcome was a response, in abstinence. So at least 3 of 4 negative urine drug screens over the course of 6 weeks in each stage. And they found that there is a significant increase in rate of abstinence for the med group in both stages. And this, just of note, was IM naltrexone that's given, or Vivitrol, given every 3 weeks. So different from what we typically give for alcohol use disorder, which is every 4 weeks. So every 3 weeks in addition to bupropion at doses of 450 milligrams a day. And then this study of mirtazapine was really the first medication to demonstrate efficacy in treating methamphetamine use. It was studied in cisgender men and trans women who have sex with men. There have been 2 independent RCTs, both with similar results. But this study, which was the most recently studied, looked at mirtazapine at doses of around 30 milligrams. And they did show that in that subgroup of patients, there was reduced meth use at 24 weeks, so over 6 months, and then again at 12 weeks of follow-up post-treatment. And they also found that mirtazapine helped reduce associated kind of HIV risk behaviors, which they defined as episodes of condomless sex, anal receptive sex, multiple partners. So it worked in both realms. All right, so many of the patients we see, as you know, stimulant use disorders, have comorbid opioid, alcohol use, other use disorders. This study from 2021 showed that people who use methamphetamine and opioids are least likely to receive MOUD. So some of the hypotheses around this was that perhaps people who use methamphetamine and opioids are less likely to be retained in care because of symptoms of psychosis, perhaps more likelihood of homelessness. But the reality is that substance use is the norm for many of our patients, and it's really important to treat those disorders concurrently. So don't forget about MOUD. Now I'm just going to spend a little bit of time on overamping. So at some point, this is a continuum that I like to show. Stimulants, on the left, often are helpful initially. Wakefulness, attention, moving into euphoria. At some point, with increasing duration, frequency of use, increasing sympathomimetic activation, that can lead to overamping. Overamping is a constellation of symptoms that often involves acute psychological and physical distress. These are some of the symptoms we typically think about in overamping. And so vital sign instability, so hypertension, hyperthermia, risk of seizures, that jaw grinding, even kind of dyskinetic movements or spasticity. We see a lot of patients who come in overamping to start with symptoms of psychosis, so severe paranoia, visual, auditory, even tactile hallucinations, people who are exhibiting protective behaviors, appropriately protective behaviors, really hypervigilance, fear, anxiety. This is kind of a graph that shows or compares symptoms of acute chronic meth-induced psychosis versus a primary psychotic disorder like schizophrenia. I think the key things here are that substance use and binge use patterns are significant risk factors for the development of psychosis. And we see auditory visual hallucinations. Tactile hallucinations are generally more common in patients who have more chronic type psychosis. We can still see them in acute psychosis, and tactile hallucinations are like formications, patients feeling like there's bugs crawling on their skin, perhaps. And as a differentiator, I think between stimulant-induced psychosis and primary psychosis like schizophrenia, really schizophrenia, we think, has been shown to have more pronounced negative affective symptoms than stimulant-induced psychosis. When we think about how to manage overamping, it depends on the severity, but really first-line treatment is non-pharmacologic management with de-escalation. Agro plus is a helpful mnemonic, I think, coming out of the Australian clinical guideline for stimulant treatment. The point is, I think, keep in mind that when people are experiencing this level of distress, they are often fearful and hypervigilant, as any of us would be. This may appear to some people as aggression. You know, an observer might be fearful of somebody with overamping, but really what people are experiencing and exhibiting is a physiologically appropriate response to their stimulant use, right? It's a protective response to keep themselves safe. And so key points for us or providers are to really think about where we are in that space, moving people to a quiet, destimulating environment or less stimulating environment if possible, where they have space, where people are not feeling threatened, using an open stance, open-ended questions, and really looking for any way in and capitalizing on that, right? So like any form of engagement, do you want some water? Do you want a snack? Do you want to take a nap? Like lay down in this exam room. This is a picture of the START clinic at BMC. This is our cool down space that we use on one side of our group room. So for patients who come in overamping, we have a cot, really inexpensive. Think about a cot, a floor mat, a white noise machine. We have an eye mask. We can close the shades. We have tons of snacks, water, fidget toys, anything that folks might find helpful, so they can lay down and just take a nap. I realize this is the most ideal looking setting, but in reality, it's often like a patient coming into the exam room, laying down on the exam table, laying down on the cot, like, you know, shoved into a corner, sleeping for 3 hours, and then waking up a different person. Our staff, importantly, front desk staff, MAs, nurses, providers, are all trained, have been trained and retrained in de-escalation. And really this space is a place for people to have some of their basic needs met, and avoid having an interaction with public safety or police. You know, over the 2.5 years we've been open, our team has never had to call public safety. Our goal is to increase trust and engagement with START staff, to eliminate those historically negative interactions that many of our patients have had, and then ultimately to decrease an ED visit or hospital admission, right? To decrease those health system costs that are associated with stimulant use. And then if non-pharm methods are not working, then medications are sort of second line. So benzodiazepines are first line for treatment in terms of meds, and then followed by antipsychotics. So this is the BMC emergency room protocol. We have an ambulatory protocol where in our clinic, we have both lorazepam and olanzapine on site for consenting patients. This is sort of the flow diagram that we follow in our outpatient site. We have START clinical guidelines, which will be available to the public in the next month, hopefully, fingers crossed. But this kind of works through the non-pharm de-escalation leading over to meds. So we've, you know, often had someone take a benzo, lay down, take a nap. 3 hours later, they're a new person, they're able to engage with us, and we've avoided an ED visit, we've avoided sort of negative police or public safety interaction. In terms of stimulant withdrawal, there are a couple different validated assessments for withdrawal. The amphetamine withdrawal questionnaire is one that was validated in the late 90s. And then the stimulant selective severity assessment for cocaine use alone or a combination of cocaine and meth can also be used. I just wanted to quickly mention this study for those of you who are inpatient providers or consult providers. It was a small trial, pilot trial of feasibility and safety, done in Australia. So it's small, but hopeful, I think, nonetheless. And this was, they treated 10 male identified patients in an alcohol and drug withdrawal unit with high doses of oral lisdexamfetamine. So some of you may know that as Vyvanse. They started at a high dose of 250 milligrams and then tapered down over the course of 5 days to 50 milligrams. They did exclude patients with other use disorders or who may have had other forms of withdrawal. And then over the course of 7 days, and then a 3-week follow-up, assess sort of cravings. And what you can see is that heart rate and systolic blood pressure decreased and then stabilized over the treatment period. Withdrawal symptoms decreased and then stabilized. And then the visual analog scale, so that the degree or rating of cravings sort of decreased and then stabilized. I know I don't have a ton of time left, so I'm going to run through this quickly, but some of the most evidence-based interventions for stimulant use disorder include behavioral interventions. START has a foundation of contingency management. So I'm just going to run through that. If you get a chance to look at this paper, you're interested in contingency management, this is one of the best meta-analyses that we have, published just a few years ago, and it compared 12 psychosocial interventions, and CM is contingency management. And as you can see, the combination of contingency management with basically any other behavioral health approach was highly effective for improving outcomes in terms of these lines represent abstinence at different time points and retention and treatment. So contingency management is based on operant conditioning principles. So essentially, an operant is a behavior that we want to see modified. So like engagement in care, reduced use, abstinence of use, and then a reinforcer is something that you're going to give to the patient to kind of help motivate along that change. And so we may think of, for instance, if we're trying to reinforce engagement in care, at the point of engagement, we may give patients a gift card or money to support that or reinforce that behavior change. This study was an fMRI study that just looked at reward processing. I think it's helpful in understanding how contingency management can really retrain the brain. So it essentially showed that human reward processing is specific to the ventral striatum, so these areas, and that it lights up with both anticipation of reward and reward delivery. I include this here again because we can, I think, with contingency management, retrain the brain to experience reward or pleasure from positive activities and behaviors in recovery. So we know that people who use drugs, people who are in early recovery, have a relative depletion of dopamine. And so CM can be beneficial in retraining those, reprogramming those dopaminergic pathways. And then just to end, running through a couple of slides on START, we're a low barrier treatment model of care. We use CM, we use exercise supported recovery. We manage acute and chronic presenting needs of stimulants. We offer gender affirming hormone therapy, HIV and Hep C care, primary care, behavioral health care, women's health care. This is a picture of our group room, and we also manage acute presenting needs of stimulants like intoxication, overamping. It's street level. It's right on the corner of Mass and Cass, so folks can just walk right in. It's in the middle of a family medicine clinic at BMC. It's staffed daily by an addictions nurse. We have a primary care providers, a multidisciplinary team, which includes a peer, patient navigator, a behavioral health clinician. We run medical and behavioral health groups. We have an art group, a walk-in group. So lots of different options for folks to engage. And then here on the right, to sort of SmokeWorks, where are they? There you are. Point. We have on-site safer smoking supplies. So for pipes, we have booty bumping kits that we give. Oh, thanks. All right, here. Thank you, Rich. You can come up and take a look afterwards if you'd like. We have on-site naloxone, so we're not sending prescriptions to naloxone. We're putting them in people's hands before they leave the clinic. We're giving them to patients. We're giving them to family, partners, whoever is there with them. This is sort of a look at our CM program, which I'll skip over. Happy to answer questions afterwards. This is our exercise program that we developed in partnership with the PT department. This is, again, a picture of our cool down space and group space. And then just lastly, a couple slides on harm reduction. So overdose prevention is huge. I think someone mentioned earlier in another presentation, Natalie maybe, naloxone is extremely important for people who use stimulants. We've had people who use cocaine, their only use disorder is cocaine, and have had overdoses in the past year from fentanyl. contaminated fentanyl. And so if you're doing nothing else, it's to put naloxone in somebody's hand. We talk about not using alone. We do a lot of, we give out drug checking supplies, test strips, fentanyl test strips, safer supply distribution. We think about MOUD for patients who consistently have fentanyl in their urines. We do a lot of screening for STIs. We have a high prevalence of patients with HIV, latent TB, syphilis. Just a note about chlamydia and gonorrhea, if you're seeing folks who are having sex orally, anally, then remembering to swab at all sites, right? So not just getting a urine chlamydia and gonorrhea, but doing a throat swab, doing a rectal swab. So thinking about the patients that you're caring for. And then it's really critical that you have providers and staff who feel comfortable counseling and prescribing with a low threshold for initiation for PEP and PrEP. And then lastly, just a note about self-care planning. And so we know that a lot of people use in binges. And so you can talk to patients about planning ahead for these events. So getting a stock of food, snacks, identifying a safe place where they can crash. And really, because we know that 1 to 2 weeks in post-acute withdrawal is really critical in terms of behavioral health needs. And so connecting people with a behavioral health provider is really critical. Another thing that we've done is we do a lot of prescribing for antipsychotics, including giving short-acting like Risperdal Haldol for patients who are not going to take an everyday antipsychotic, but who have persistent psychosis whenever they use in binges. And so they go to a party, they take their Haldol with them in their pocket, right? And just some resources. So we do have the Graken TTA team has a couple of different stimulant related trainings. I would encourage everyone to check out this tip from SAMHSA, the treatment of stim use disorders. It's excellent. And then if anyone's considering CM, then the Opioid Response Network has a consultancy around this specifically. Thank you.